So this is a busy graph, but basically it shows the individual steps. So a patient is identified as a potential candidate for telestroke. A phone call is made to the referring site, and that will be either activating through BC Bedline, that's probably the best way, or through a dedicated stroke pager. You should always know who is supposed to be picking up at the other end of the line. Then there's a communication that goes on where there's a brief screening process where it's determined whether or not this individual is a candidate for telestroke or whether it's just an advice call. Subsequently, you prepare the sites for consultation, so the consultant will go to the room where the video setup is. The cameras will be placed, of course, at the sending site. The CT scan will have been done. Appropriate blood work is in progress, and the telestroke then ensues. The telestroke consult itself usually takes about 30 minutes. It's variable, and it's amazing what you see. You see patients on screen getting better, you see patients getting worse, you see the evolution of stroke mimics such as focal seizures, and this is all done in real time. So once the consultation is done, then a recommendation is made to the on-site physician or the most responsible physician on-site. It may be the emergency physician or subsequently an internist or another designated physician, and treatment is provided. There's the ability to do follow-up either by phone, by review of subsequent images, or even by telestroke follow-up. So this is our basic system. This is at the referring site. You can either have it ceiling mounted on a dedicated stretcher bay or portable. I think the portable system works very well. And you have a camera that you can which we can control from our end so that we can zoom in and zoom out and move side to side and move the camera to look at the physician or the nursing staff or the patient or spouse. And this is what we see on our end. And the resolution of this system, there's the camera that projects the consulting neurologist to the far end, and this is the screen that we see and we control from our end. So at this point, I'm going to turn over to my colleague, Dr. Andrew Penn in Victoria. Jen, can you unmute the line at Victoria VGH, please, and just give me a voice signal so I know that they're live there?
Hi, I'm just unmuting Victoria.
Thank you. We'll take questions at the end of Andrew's presentation. Andrew, I think
for the process of setting up telestroke, as I think in our future we'd like to see a network across the whole province, including many of the sites who are being video conferenced today. I should start off by saying that in countries in which there has been a strong telestroke initiative for some time, Germany being notable, there are centers there who do more TPA through telestroke than they do face-to-face. So the people in the main teaching hospital may be giving more TPA using the video conferencing equipment than they are in their own emergency room, which is a good testament to the ability of this system to be able to reach out. And certainly in a country like Canada, which is much more geographically spread out than Germany, there is even more reason for doing this. Can we have the next slide? I don't know if Phil, hopefully Phil can hear us. Great, thanks. So Phil's already shown you some of the technology. This is the unit that is being used at Cowichan right now. Cowichan chose to have a fixed unit, so it sits up in the ceiling against the wall. There's a camera there, and that it's in a specific bed, which is their emergency bed for stroke. I'm not sure what other function it serves up there, to tell you the truth, but
it's a trauma bay.
It's a trauma bay. Okay, so I don't know what happens if a stroke comes in, if there's a crash victim in there, if they have to move over or they scrap for it or maybe flip a card. At any rate, we haven't had problems with that. And the camera is controlled by us back in Victoria, so we can swing it around to look around the room, to direct it at the family if necessary, and that sort of thing. And the sound is very good as well. Then back in Victoria, next slide, we have our stroke consulting bay, if you like. It's in our stroke rapid assessment unit where the neurologist is seated anyway, managing stroke patients, TIA patients during the day. And the three screens, the one on the far right is the video conferencing screen, and there's the little panel below that you sort of zoom the camera around with. And then on the middle screen we have the PAC, so we look at the imaging. And on the far left screen we have the electronic health record, and so where we're keeping our notes as we examine the patient. So if I'm filling out an NIH stroke score, I can do it live as we're following them and look at the images as we're discussing the patient. And the situation, I don't have any slides for Phil's setup. The difference, I think, between the Vancouver situation and the Victoria situation are a good way of exploring different setups that might occur across the province. Essentially what's happening in Victoria is we're extending a process which already exists, because when you're on call for neurology, you're looking after calls from the NIMO and the rest of your region. So we're responsible for our region when we're on call. So these guys are phoning us anyway. What this does now is adds a video camera to the previous system of using a telephone. And the numbers on Vancouver Island are 750,000. Whereas in Phil's situation, you know, we've got 1.3 million people in Vancouver Coastal alone, and then Fraser gives you another 1.5 million. So we've got a much bigger group, a much busier possible scenario to be dealing with, and maybe less well-forged referral pathways. So there may be hospitals referring for stroke who don't phone up Phil to talk to him about Guillain-Barré syndrome or something like that. So it's a slightly different system. And I think probably Phil's system closer to what we would imagine in the future, where we might have one base like what we see here in front of you that is got one neurologist looking after the whole province. And that certainly is what happens in Ontario for the most part.